Okay, so I've been charged to talk to you about how to optimize left main PCI using intravascular imaging criteria. These are my relevant disclosures. So the first question is sort of, what's the big deal here, right? This is just PCI. Why do we have to have different optimization criteria? Well, the big deal is that between the LAD proximally and the circumflex, you cover about 80% of the heart, right? So if you cover 80% of the heart, you got to get it right, because if you don't get it right, you're going to have problems. You can see on this CT data that the proximal LAD and circumflex are covering about 80% of the myocardium. And the other reason that it matters is that if you cover 80% of the myocardium and you get it wrong, you have really bad outcomes. And you can see that the 5-year endpoints for Excel, which are hard endpoints, death, stroke, or myocardial infarction, about 1 in 6 patients actually has an endpoint. So I'm not sure we consent patients when we do their left main PCI by saying 1 in 6 of you is going to be dead, have a stroke, or have a heart attack, but the stakes are very high. But I put in big stents anyway. So what does it matter? I mean, I think what we've shown years and over again is that the way intravascular imaging and technologies help is for you to put in bigger stents. But nobody's really putting 2 5s in the left main anyway. But it does change things. This is data from Excels, which shows you use a larger balloon, which means if you're going to use a 4.0, you use a 4.5. You post-daylight more commonly. You use higher pressure. You treat stentor under expansion, which means that's an optimization round following your IVUS, more provisional stenting, and changes in the planned 2-stent strategy. And this is data from the CAMER registry, which shows if you look at all the complex PCIs, IVUS imaging improves clinical outcomes compared to angiography at long term, and you'll notice that left main PCI actually stands out among the different subsets of complex PCI, showing very specifically the improvement in the hazard ratio, really unparalleled to the others. Meta-analysis for major adverse cardiovascular events are consistent with this and show that IVUS-guided PCI in the left main reduces basically everything: MACE, death, cardiac death, myocardial infarction, and stent thrombosis. But, it should be the same as any other PCI. But there are specific strategies and things that matter in the left main that really don't matter in most other PCIs. And that is provisional stenting across a big branch, isolated stenting of only the left main without crossing over, performing ostial stenting in a highly muscular part of the artery, as well as ensuring that we don't miss the ostium. And then, of course, if we're doing crossover stenting, we need to think about what the impact of the struts, as we were just learned about, what the impact of those struts potentially could be. And then when we do 2-stent strategies, things become much more complicated. The measurements become more complicated. How do we meet in the carina? What about the polygon of confluence? How big should it be on the right side versus the left side? And then the dynamic range of the stents really matters. So if we put a smaller than 3.5 stent, we can't get it to 4.75 or larger, so we can end up causing problems. But left main PCI optimization in that regard does have evidence to say some target zones. Now, the target zones in regular PCI are not really great either. We came to the European consensus document to get to an 80% expansion, but really there's very little evidence to suggest that an 80% expansion reduces clinical outcomes. In fact, the thing that improved clinical outcomes in any vessel is the minimal stent area. The beauty about the left main is, as far as I know, it's in the same place in everybody, at the beginning of the coronary trees. And so finding an absolute cutoff for the left main actually is different and more efficacious in terms of clinical outcomes than is in other parts of the artery. This is the original data from Kang. Of course, this was criticized because it doesn't really fit with Caucasian populations, for example, in the Americas. So we repeated the Kang data from the Excel data, and you were also just seeing the Noble data from Dr. Chowdhury, which shows that our goals in terms of minimal stent area and polygon of confluence are very different to what they were originally. Why does it matter? It matters because bigger is better, and you can see categorically that if you have a larger minimal stent area, you have less hard endpoints as well as less stent thrombosis. Several years ago, we brought up this concept of MLD max. So MLD max really was an algorithmic approach to PCI, and it took away all the things that we look for on imaging that don't impact the outcome: tissue protrusion, macrophages, cholesterol crystals. When we looked at Illumian 3, we found these were the things that directly impacted clinical outcomes. Morphology, really because of calcium; length, going from normal to normal; diameter, to get the biggest possible stent in; and then post-PCI, medial dissection, apposition, and expansion. So let's do a case. Here's a patient with a left main lesion. You can see the appearance of what looks like a calcified nodule. We can't be absolutely sure. So if we do morphology of the circumflex, what we see here on our pullback is a really very normal vessel up until when we get to the more proximal part of the circumflex, where we start to see some circumferential calcium, but with a very large lumen area. And as we continue along here, what we are going to see very shortly is the presence of a calcified nodule. And so what you can see are there are specific characteristics about this calcified nodule which are important. You can see that it looks spiculated, and that means that this is an eruptive calcified nodule, and I'm going to talk to you about why that's important in just a second. Now, what do we see on our left PCI, pre-PCI morphology? We see an eruptive nodule, we see some mixed calcium morphology, and we see a protruding nodule more distally. We created a calcium scoring system so that you know how you should treat calcium and when we should perform advanced lesion preparation. When we have this mnemonic: calcium laden. When you have circumferential calcium, a length of calcium that's 5 millimeters with an arc of 270, when the lesion is, or the vessel is less than 3.5 millimeters, just adjacent to the calcium, or nodular calcium, each gets a point. And put simply, if you have 2 or more points, you should think about advanced lesion preparation, rotablation, shockwave, NC, etc. When we do length measurements are actually really easy. What we end up doing is scrolling into the lesion and then scrolling back out of the lesion until we find a normal landing zone and simply making measurements. What makes the left main different is we need to make sure that we have enough space to do a pot. And so what you don't want to do is stent very short and end up with only 2 or 3 millimeters in the left main, which makes the pot much more difficult. And here you can see we're just literally performing the measurements. And what we're going to do is place our bookmarks on either side and do all of our measurements, showing that we have an 18 millimeter device, and that gives us enough 8 millimeters to perform a proximal optimization. Diameter measurements are EEL rounded down, if at all possible. If we have a 50% plaque burden or greater, we use the lumen and size up. That minimizes our risk of dissection. What about morphology in the LAD? So in the LAD, we again see a heavily calcified segment of the artery, but for the most part, the artery, at least more distally, looks normal. And then what you can see using IVUS is that right after the bifurcation, there's a tight lesion. So this really is a left main lesion and a very osteal LAD lesion. What do we see? An eruptive calcific nodule in the left main. We see a protruding nodule more distally, and non-nodular circumferential calcium with a good lumen. Length, same measurements. We can measure from the distal reference in an area that we would want to land our stent all the way back to the left main. We can mark our left main very easily using IVUS. And so here's our measurements. We know exactly, much like a TAVR, before we go in to do this now, exactly what stent, how size, what optimization balloons, so everything can become more quick. Now here's pragmatic predilation. An eruptive calcified nodule we can test because we know the eruptive nodule will get pushed out of the way with the balloon. Most people would have seen this eruptive nodule and started to do rotablation. We now know, because of the IVUS, that we saw an eruptive nodule instead of a protruding nodule, so pragmatic predilation pushes the nodule completely out of the way. And as a result, this then becomes very straightforward. Instead of doing advanced lesion preparation, because we had a low calcium score, is simply placing a stent. Following this, we're doing a standard culotte technique. We perform a balloon dilation. We cross over through the new strut, make some space for ourselves, place our drug-eluting stent, again measured 18 millimeters on either side, recross, perform a proximal optimization technique, and then do kissing balloon inflation. And following a kissing balloon inflation, now what we need to do is actually do IVUS on both sides post. And so the post PCI here is actually very quick. We quickly look at the distal stent edge and the proximal stent edge. We quickly look for apposition. All of the post PCI assessments should not take more than a few minutes, and we can measure the expansion in the left circumflex, which meets the criteria according to both Kang and Excel. The left main also is very large, greater than 12, and fits in the highest tertile, which shows we're going to get a very good result. And we can quickly assess the LAD for medial dissection, apposition, and finally expansion. And so I think what I've shown you in the last few minutes is that if we use the same algorithmic approach that we use in other vessels using MLD Max and understand the nuances of the left main, we can actually have a very good job and get to our optimization criteria in the left main. Thank you very much.